Perfect. All right. So, my name's Holly Ledyard. I might have met some of you previously. I was over there in 2017, or 16, 17. I can't remember. At Cho Ray, with Dr. Fuller and Dr. Ernst. And then I presented at VSEM this past fall, and I don't know if any of you guys were there, but Ryan asked me to speak to you guys about the emergent management of traumatic brain injury. So our goals are we're going to first review some relevant definitions and kind of basic pathophysiology. We're going to talk about the emergency department management of moderate and severe traumatic brain injury. We're going to discuss our options for management of severe traumatic brain injury in low resource settings. All right. Up to 70 million cases of traumatic brain injury occur worldwide, the majority happening in low to middle income countries. And it's currently the leading cause of disability. Globally, the median age of traumatic brain injury patients has doubled since the 1980s. So as our population ages, the age bracket of patients getting brain injuries is also shifting. We can classify traumatic brain injury into three categories. The majority fall into the mild category with a GCS of 14 to 15. The remaining 20% is split evenly between moderate and severe, with a GCS of less than or equal to 8. So when you have a brain injury, you have the primary injury, which is the physical structural damage to the brain that happens at the time of impact. This is followed by secondary injury. Secondary injury is microscopic damage from the primary injury. You get expansion of the original injury due to potassium and sodium shifts, mitochondrial damage, as well as free radical production. There's damage of axonal transport, which leads to apoptosis. And this subsequently leads to edema and compression of the surrounding brain tissues, which can cause ischemia, herniation, and brain death if severe. Sorry, I'm trying to move my little face brackets. Just a basic review of pathophysiology. Intracranial volume is about 1,400 mLs, about 80% of which is brain tissue. An additional 150 mLs is blood, and 150 mLs is CSF, which is constantly circulated throughout the course of a day. And as you can see on the bottom, this just depicts the little brown spot as a space-occupying lesion of any sort. You have your skull, which is a fixed box, and these components within that fixed box. The brain these extra spaces, the blood and the CSF, can accommodate some room. So up to 300 mLs worth of room potentially. But as that space-occupying lesion, whether it's a tumor or blood, grows larger, then the blood component and the CSF component are so squished, the brain has nowhere else to go but out. And this is just a picture reminding us of all the different ways the brain can herniate. So if there's a hole in the skull, it can herniate outwards. You can have subfalcine herniation. central or transtentorial herniation, uncal herniation, cerebellar tonsillar herniation. You can even have upward cerebellar tonsil herniation. That's rare, and usually in the case of somebody who has an external ventricular drain in place that is draining too much. Another important concept to know about is cerebral perfusion pressure. This is the pressure, the amount of pressure that the brain requires for perfusion. It's kind of a surrogate for cerebral blood flow. CPP is equivalent to the mean arterial pressure minus the ICP. So when the ICP increases, the CPP decreases, which means your mean arterial pressure has to increase to accommodate and maintain normal cerebral perfusion pressure. Most patients are able to do that by themselves. The brain's really good at auto-regulating within this zone of 50 to 150 millimeters of mercury. If you get below 50, then you get hypoperfusion, which leads to ischemia. If you're above 150, there's hyperperfusion, which leads to hyperemia and edema. So it's a decent range, but sometimes patients need help with autoregulation if their brain is severely damaged. So let's walk through kind of our ABCs regarding traumatic brain injury. So one thing we want to do is avoid hypoxia. Hypoxia and hypotension are the most important causes of secondary brain injury. They should be avoided at all costs. Hypoxia means an oxygen saturation less than 90% or a PaO2 of less than 60. So in patients who have a Glasgow Coma score of 8 or less, we want to try and intubate these patients early. If you know you're going to intubate, do your best to try and pre-oxygenate. The no DSAT protocol is basically just apneic oxygenation. So you have passive oxygen flowing even after you push your induction agents and paralytics. As far as pre-treatment goes, back in the olden days, we used to pre-treat with lidocaine to blunt the sympathetic response to laryngoscopy. However, it's been proven that there's no clear benefit to doing this. You could consider using some short-acting opiates, like 2 to 3 mics per kilogram of fentanyl, but only if the patient is hemodynamically stable. As far as induction goes, etomidate has been well studied. It has a very stable hemodynamic profile, and it is out of the system relatively quickly. You can also consider ketamine. There was an old dogma that ketamine raised intracranial pressure. However, this is proven to be untrue. It may actually help improve cerebral perfusion pressure in these patients. And then as far as paralytics go, rocuronium or vecuronium versus succinylcholine, depending on the patient and what your goals are. So if you want to re-examine your patient very quickly after intubation, I would recommend succinylcholine. But as we all know, succinylcholine has potential downfalls of raising potassium. So if you've got somebody with a crash injury or maybe renal failure, you have to pay attention closely to their electrolytes. If you've got a patient who's super combative and you need them to lay still for CT imaging, rocuronium might be a better option, or vecuronium, one of the longer acting paralytics. And we've in the recent, past 5 years or so, there's been a focus on C before A, so circulation before A, or RBI, as we call it, resuscitation before intubation, especially if you, not only for hypotensive patients, but patients who you anticipate may become hypotensive once you take away their sympathetic tone. So, what we recommend is aggressive resuscitation prior to intubation to minimize your risks of decreasing their mean arterial pressure with your induction agents. We always have push dose pressors on hand that can be rapidly pushed to treat hypotension if it does occur. We want to avoid both hypo and hyperventilation. Our target PCO2 is between 35 to 38. And a PCO2, some people say 30, some people say 25, should be avoided. You can use quantitative capnography that might be useful. Once you know where your PCO2 is, you can match it to the end tidal CO2 and kind of keep it in a relatively similar range. Hypotension is the most important cause of secondary brain injury. A systolic blood pressure of less than 120, so 120 is pretty normal, increases the risk of death by 50%. And that risk triples with systolic blood pressures of less than 90 in adult patients. So our blood pressure goals are based on outcomes for age ranges. If your patient's between 50 and 69, we should target a blood pressure of greater than 100. Patients between ages 15 to 49 and over 70, we should target a systolic blood pressure of greater than 110. And regardless of age, we want to try and keep our mean arterial pressure greater than or equal to 80. For fluid resuscitation, use normal saline. Lactated bringers or Plasma-Lyte, although they are more balanced electrolyte solutions for your general trauma patient, they are relatively hypoosmolar compared to normal saline. And if you've got a patient who's got cerebral edema, then this could potentially worsen your edema. We also want to avoid albumin. One of the crash trials looked at fluid resuscitation, and albumin was strongly associated with worsening outcomes. As far as pressor choices, generally speaking, in the US, we use norepi, but you can also consider phenylephrine. There was interestingly one retrospective study that suggested a mortality benefit with phenylephrine compared to norepi in patients with severe traumatic brain injury. And the thought was that it might be associated with less cell injury than norepi, and it also can increase your cerebral perfusion pressure without increasing your intracranial pressure. So just something to keep in mind. Obviously, if the patient's bleeding, we want to stop that bleeding. Maintaining a hemoglobin greater than 7 is important. In your elderly population, we usually target greater than 8. You're also going to treat coagulopathy. So patients who are on blood thinners, you're going to give reversal agents to if they are available. Tranexamic acid was studied in the CRASH 3 trial. They demonstrated a reduction of TBI-related death, but only when given to patients with mild to moderate TBI and within the first 3 hours. There was unfortunately no benefit for severe traumatic brain injury. If you're going to use TXA in this setting, it's 1 gram over 10 minutes, followed by an infusion of 1 gram over 8 hours. A neurological examination should be completed as soon as possible to help determine the severity of the TBI. A pupillary exam is also crucial. Neurological status should be reassessed frequently as rapid changes can occur that would prompt different treatment. You need to manage suspected increased intracranial pressure immediately and consult neurosurgery if they are available. exam findings concerning for impending herniation include decorticate or flexor posturing, decerebrate or extension posturing. A unilateral fixed dilated pupil could indicate uncal herniation. Bilateral fixed and dilated pupils can indicate bilateral uncal herniation. Bilateral fixed pinpoint pupils might point to a pontine source. Loss of cough, gag, and corneal response indicates brainstem compression. And Cushing's triad of hypertension, bradycardia, and irregular respirations is concerning for impending herniation. And it's something you should act on immediately. As far as imaging goes, a non-contrast CT head should be performed as quickly as possible. This can detect skull fractures, hematomas, and cerebral edema. Imaging should be repeated with any significant clinical deterioration. And if you find any kind of hemorrhagic lesion on your initial head CT, you should repeat a head CT 4 to 6 hours afterwards to document hematoma stability. If the hematoma is worse at that stability scan, you would repeat these images every 4 to 6 hours until that bleeding is stable. You can consider CT angiography to screen for blunt cerebrovascular injury, depending on the patient's mechanism or presentation. The expanded Denver criteria can help you decide who should have that imaging. And once we know we have a patient with a severe traumatic brain injury, the method to managing these patients is important. So first of all, you want appropriate positioning of the patient in reverse Trendelenburg with the head of bed at least 30 degrees. This helps promote venous drainage from that fixed box that's already angry. Maintain neutral neck positioning and avoid compression of the cervical vasculature. Sometimes this means we take off the anterior part of the collar and put pillows or weights on the side of the head so the patient can't move back and forth. You can use moderate hyperventilation. We're talking to a PCO2 between 32 and 35. Again, remember, don't get less than 25. This is only a temporizing maneuver. Hyperventilation works by vasoconstricting, so arterial vasoconstriction. And so you're decreasing that blood component in the intracranial space. But when you constrict the arterial vasculature, that also decreases the cerebral blood flow. And when you have an already angry brain and you're delivering less than optimal blood flow, then your risk of secondary injury can start increasing pretty rapidly. So we use hyperventilation in the setting of this patient's herniating and I'm trying to get him to the OR for definitive management. And then we stop. It is not a prolonged treatment modality. Sedation can be used to reduce cerebral metabolism. We generally use propofol. Sometimes patients require very high doses of propofol. And when their CK and triglycerides start going up, we'll switch gears to midazolam. But midazolam is a perfectly fine agent to start with if that's what you have. Osmotherapy is an important mainstay in ICP management. You can use mannitol with doses of 0.25 to 1 grams per kilogram, either pushed up through a filtered tip needle or pushed through a filter because mannitol has a tendency to crystallize, especially in cooler temperatures. Mannitol is an osmotic diuretic, so it pulls fluid out of the body and gets rid of it through the kidneys. So you have to have functioning kidneys in order for it to work. Somebody who's on dialysis or has bad kidney disease and makes very little urine, is mannitol is not going to be very effective for. If your patient is volume down at all, this is going to make them hypotensive. I generally make sure that my patient has a Foley in, and then I watch their urine output after we push the mannitol, and I'll replace whatever they pee out with isotonic fluids. Hypertonic saline comes in many different strengths. The most common in the US are 3% and 23.4%. We'll generally give the 3% in 250 to 500 ml boluses. If we're using 23.4%, we use 30 mLs, and it should be pushed through a central line because it's very, very caustic to the veins. You can make a sodium goal between 145 to 155, depending on how the patient responds. And your goal serum osmolality is between 310 and 320. Some patients require surgery for their traumatic brain injury. The indications for surgery include an epidural hematoma that's greater than 30 mLs with a GCS of 8 or less, or a 2-point decline in GCS. A subdural hematoma greater than 10 millimeters with greater than 5 millimeters a shift, a GCS of 8 or less, or a 2-point decline in GCS. A posterior fossa hemorrhage that has compression on the fourth ventricle, or the patient's developing obstructive hydrocephalus. A depressed skull fracture where the depth is greater than the width of the cranial thickness, or there's dural penetration. Regarding seizure prophylaxis. So anti-seizure medications are generally recommended to prevent and treat post-traumatic seizures in patients with any of the following: a depressed skull fracture, penetrating head injury, subdural, epidural, or intracerebral hematoma, a GCS of less than 11, or a seizure within 24 hours of injury. Seizure prophylaxis reduces the incidence of early seizures, but it does not prevent later development of epilepsy or improve mortality. I'm not sure what you guys have available to you. Generally speaking, the guidelines say that phosphonatoin or levetiracetam are acceptable. We tend to use a lot of levetiracetam due to its lower side effect profile. Phosphonatoin has a lot of liver interactions, and it can cause hypotension, as well as depressed mental status. And so we tend not to use a whole lot of phosphonatoin. And then if a patient is intubated, your sedation modalities, propofol or midazolam, can also be helpful in preventing seizures. If a patient does seize, you'd manage these just like you would any other seizure with benzodiazepines as your first-line agents. Now, what about traumatic brain injury in a low resource setting? So resources in many low to middle income countries are often limited. The frequency of TBIs are often higher in these countries. They're associated with higher morbidity and mortality, as well as disability. And physicians in lower to middle income countries have almost no evidence-based guidance to assist in the management of severe traumatic brain injury. So a couple of things, and the ability to place an ICP monitor or an extraventricular drain and have continuous monitoring of ICP may also be limited in these settings. One thing we can use as a means of non-invasive ICP monitoring is pupillometry. This uses a combination of infrared and visible light to capture variability in pupillary light reflexes. It can track pupil size and reactivity, and objectively detect subtle changes in pupillary responsiveness. There's really no agreed upon threshold for changes that correlate with clinically important changes in ICP, but one of the numbers that you get is called the NPI. And the NPI is a measure of pupillary reactivity. It's on a scale of 0 to 5, 5 being very brisk. Anything above 3 is normal. An NPI of 0 would indicate a completely non-reactive pupil. I have one here, and I'm just gonna show you guys what this looks like in real life. Okay, so this is an old, maybe, if it'll turn on. Let me see. Hello. No. My model is finicky. It's a very old model, and it looks like it doesn't want to turn on. I'm going to plug this in and see if it'll charge. And at the end, we'll bust it out. Okay, it looks like it's charging. All right, sorry. Okay, another means of non-invasive monitoring that you might have at your disposal is point-of-care ultrasound. So you can measure the optic nerve sheath diameter in patients with elevated intracranial pressure. The optic nerve is an extension, a direct extension of the brain meninges. An elevation of intracranial pressure is directly transmitted to the sheath. So on point of care ultrasound, you're going to find the optic nerve at the level of the optic disc, which is this little bump in the back. You're going to freeze your image. Then you'll see the optic nerve, which is hypodense, immediately behind it. And then you've got these stripes on either side. And this is the optic nerve sheath. So you want to measure from the outside diameter to the outside diameter. And this nerve sheath should be less than 6 millimeters. An optic nerve sheath diameter greater than 6 is consistent with ICPs greater than 20. And optic nerve sheath diameter measurements have been shown in the literature to have reasonable accuracy in diagnosing elevated intracranial pressure. Now, in 2012, the BEST TRIP trial was published. This is a landmark publication by Randy Chestnut, looking at managing traumatic brain injury, either with standard of care based on directly monitoring intracranial pressure or managing patients with imaging and clinical exam. And what they found in this study was that there was no difference in outcomes between patients that were managed based on continuous ICP monitoring versus imaging and clinical exam. It was noted that the ICE arm was less efficient than ICP monitoring because these patients often required many trips to the CT scanner and more frequent examinations. Subsequently, the crevice algorithm was created, and this is based on a consensus statement of 43 physicians who regularly, in their routine practice, manage severe traumatic brain injury based on imaging and clinical exam. And this was put together responding to the absence of guidance in the literature for patients in countries who don't have access to sophisticated monitoring techniques. I don't mean to go through this whole thing. You can find the nitty gritty of this in the Journal of Trauma, and that was published in 2020. I have the reference down here at the bottom. But this just shows you the algorithm for patients that are managed in the imaging and clinical exam tier. So they have different tiers of treatment they start at tier 1. If tier 1 fails, you go to tier 2. If tier 2 fails, you go to tier 3. And they document what things are not used. And then if things aren't responding to tiers 1, 2, and 3, then they go to neuromuscular, or they haven't resolved the issue of whether or not they use neuromuscular blockade. So this is just an example of the algorithm that is recommended in that crevice trial. So in summary, we're going to avoid hypoxia and hypotension at all costs. We're going to aggressively resuscitate patients requiring intubation and make sure you have pressors on hand in case they do become hypotensive. If you're going to hyperventilate, don't do it for too long. Use it as a bridge to more definitive therapy. Early osmotherapy can be helpful in preventing spikes in intracranial pressure. And then don't worry if you don't have all the fancy tools to closely manage elevated intracranial pressures. You can still take excellent care of patients without them. Here are my references, including that the crevice trial here. And then I'm going to see if I can get this peopleometer to work. It is just not charging. I apologize. It's kind of a fancy tool. It's something small that can be kept in the trauma bay and utilized by physicians or nursing to monitor patients. Especially, we use it in the ICU oftentimes in patients who are paralyzed because of their elevated intracranial pressure, and we can't get an exam other than pupils on them. So, what questions do you guys have?